There we go. All right, you're all set.
Okay, anyway, that's us. We're going to be talking about women in ADD with a particular focus on menopause. A quick review of the history of ADD, and I won't belabor this, but goes back for many years and kind of the peak things. I have underlined that early on they saw the impulsivity, the inattention as something that got picked up many years later, which is relevant because women tend to be more often inattentive. Um, First trial of stimulants, I don't know if people know that, was in the 30s with Bradley and was an accident. I don't know. He synthesized X, and there was no ethics committee back then, and he gave these children who were under his medical management Dex. I don't know what he was thinking, but he found the paradoxical effect. Anyway, this is the history, and basically, from the 50s on, there was an explosion in research in ADD. And this guy, the German psychiatrist Heinrich Hoffmann, back in 1844, wrote a book for his 3-year-old child. And we're going to take a look at that. Uh, this is Strobe Peter. And in this book, which is amazing, it's basically got like all of child psychopathology in cartoon form that he created for his 3-year-old. Some of the stuff is pretty bad too. This is Zapplica Phil, which means fidgety Phil. And you can see what he's doing. He's knocking over, he's fidgeting at the table and spills all the food. It's the hyperactive kid. And then we have Hans guckende Luft, which means Hans who looks in the air. And he has inattentive ADD, as you can, I'm inferring, as you can see, the kid's walking along and he doesn't notice that he's about to fall off a cliff. So it's interesting that he did this, that he picked up on the inattentive type long before it was recognized in mainstream medicine. Then the name changes of ADD. It went from MBD to ADD to ADHD type, ADHD presentation. It reflects evolving understanding of ADD itself. And I don't want to belabor it because I don't know that we have time to go into it. But it just, MBD, just to draw attention to it, that was when they thought it was a minimal brain dysfunction, but they didn't know what kind. Hyperkinetic is when they focused on the hyperkinesis. Then later on with the DSM-3, they noticed inattention. So they had with or without hyperactivity. Anyway, this is for people that are interested, this is a kind of a quick summary of what the names changes have been and the evolution of the underlying understanding. What issues regarding ADD? It's a neurodevelopmental disorder. It used to be considered a disruptive disorder. Now they've understand that it's neurodevelopmental. It's strongly genetic with a heritability index of about zero point 0.7. That's why it's very common when a child gets diagnosed, one or the other parent says, "Oh, that sounds like me," right? Because of the strong heritability. They used to think, and I was part of that, they used to think that people outgrew ADD. What they were really outgrowing was the hyperkinetic part. In the 1990s, they started recognizing that a substantial percentage of the people did not outgrow it, and that led to the construct of adult ADD. And this one, in the 2000s, there was an introduction of the concept of adult onset ADD. And it was based on the claim that 68 to 90% of adults with ADD did not have symptoms in childhood. Those were population studies. There were lots of methodological problems. And I think adult onset, the whole concept, I think it was what did they call it? A flash in the pan. I don't think there's much attention to it anymore. The 1990s, I want to back up a moment. It was pivotal. There was just an explosion of understanding that it continued into adulthood and a flood. There was a book back then written, Driven to Distraction, which I think you probably know. I used to joke that my whole practice was for a decade was filled by people reading Driven to Distraction. Anyway, so the 1990s were pivotal. And here's most of the research in ADD was in males and continues to be in males. ADHD in females. Presentations of ADHD in females are different. There's a greater male to female ratio during childhood, which evens out during adulthood. So it's not recognized. It's not that it isn't there. There's different expression of some symptoms, so it's misunderstood. Hyperactivity is seen in speech, motor mouth, little girls that are jabber, 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 whereas guys are much more physical. As a group, modal tendency, there's always obviously differences. I mean, people overlap. Girls have a lot of impulsivity in sexual and other indulgences. There's much more pregnancy. The girls are often misdiagnosed because ADHD traits can be mistaken for depression or anxiety. And the girls have learned to mask their symptoms due to increased social awareness. Guys let it all hang out. Girls notice that they're different, and they get the feedback that they're different, so they try to rein it in. But that's why it's missed. Overall, ADHD in females is, I love this is my phrase, missed, disguided, and buried, as we're going to discuss next a little bit more. Since the research is primarily the clinical differences between the sexes not examined, there's a gender bias. They're much more likely to diagnose a kid as ADD if they're a guy. If a girl has ADD symptoms, it might be called anxiety or something else. Differences are not seen. Females are more likely to be inattentive and or show different manifestations in the hyperactivity. So it's missed. Females are inclined to mask symptoms or compensate for them. What I talked about is the social awareness, so it's disguised. And often they look, the clinicians seeing the kid, see the anxiety, see the depression that is either comorbid or as a result of the ADD, but they miss it and they say kid's anxious, kid's depressed, kid's got an adjustment disorder with anxiety and depression. And they miss the fact that that they have ADD, so that's buried. And what's this last one? I don't know where that 4 comes from. Hormone fluctuations impact all females. Okay, common comorbid disorders. ADHD females have more depression than neurotypical males and females, and more suicide. So, I mean, these next couple statements I think are important because we have to compare the ADD female to the rates with ADD males and non-ADD females. So what you're seeing here is that women with ADD are much more likely to be depressed and even commit suicide than ADD males, certainly than females, but even males. My point there is that, it's well known that ADD males have a lot of psychological problems. The women are more likely to have anxiety disorders than neurotypical females and ADD males. Teen pregnancies, eating disorder, self-harm, more postpartum depression, more premenstrual dysphoric disorder. So a lot of everything more. Peer relationships, issues vary with the type of ADD. Inattention predicts victimization and self-harm. Impulsivity predicts relational aggression leading to high peer conflict. Externalizing disorders are seen more in impulsive presentations, and they predict peer rejection, which predicts future suicidality. This is so bad when you go through this. Social and emotional challenges lead to elevated stress. That's kind of a silly statement. But okay, hormones and ADHD in females. Like I said here, it's the wild, wild west. There's very little research. The literature contains almost no discussions of the impact of hormonal fluctuations. For example, none of the following major reviews from the 2020s consider hormones. And these are, very current and cutting edge journals and cutting edge authors. And they're all about girls and women. Systematic review. Nothing talks about hormones. And we are like, very hormonal. Okay, women suffer huge hormonal fluctuations, times of major transition, puberty, monthly menstruation, the pregnancy, postpartum, and climactic. For those of you who don't know what that is, that refers to the period when you're transitioning from normal menstruation to being postmenopausal. So those are all times of major hormonal fluctuation. So let's look at it. I like pictorial representations of things. All the way on the left, you see the men. They don't use the O. I mean, they use the O and we don't. Anyway, as you can see, the estrogen builds up. In the middle of the in the middle of the month, it drops off, and progesterone it comes up. That's where the ovulation happens. Anyway, the big picture here is that there's huge changes in the estrogen and the progesterone and the ratio of them to each other. That apparently matters too. Over the course of a silly, simple 28-day period. Now, during the climactic years, it's worse. The estrogen's going down, progesterone is going all around, luteinizing hormone is trying to make you produce. I mean, the hormones are in big flux. We'll look at more pictures of that. Okay, so some interesting basic science facts regarding female hormones and cognition. Low levels of estrogen have been linked to a number of other conditions. Alzheimer's disease, that's the largest body of research where they see that there's an increased incidence of Alzheimer's disease in women and not men, increased incidence in women who have earlier menopause. So, and then there's what's been noticed as miscellaneous cognitive deficits, especially verbal fluency and memory fluency. That's women come in and complain in the perimenopausal years. And even there, fluctuations in estrogen has been associated with psychosis and mood disorder. We're going to look at that a little bit more closely. The role of estrogen in cognition was historically studied through the effects of estrogen manipulation in women. So with dementia, they would try to either treat dementia or prevent the onset of dementia with hormones. Surgically induced menopause is women who had to have their ovaries removed for some reason or another, and they get compared to women who are the same age and haven't had that, and they're comparing the cognitive functioning. And postmenopausal women complaining of cognitive problems. We're going to look at that a little bit more closely. This is a very interesting figure. This is the top line is estrogen levels fluctuating over the female lifespan. And underneath the blue line is prevalence rates for depression. Do you see how they parallel each other totally? And it's interesting, high estrogen is associated with depression. Meantime, high estrogen is associated with less ADD symptoms. So um, I'll get into that a little more. Okay, the impact of female hormones on ADHD. The hormonal surges are associated with neural changes that increase the risk for internalizing disorder. That kind of fits with the mood thing that we just saw now, right? Fluctuating ratios of estrogen and progesterone affect symptom severity. There's been whole books and studies about being an estrogen type or progesterone type. It's all being sorted out, but it's research on women, so it's very behind, and we're complicated. Low estrogen or dopamine states exacerbate ADHD symptoms and comorbid internalizing disorders and high trait impulsivity. People with high impulsivity are vulnerable to hormone-mediated depression with increased risk of suicidality. Anyway, that's not exhaustive. That's just a couple examples. During the menstrual cycle, hormone and ADHD symptoms fluctuate. During the follicular phase, which is as the estrogen is building up, ADHD symptoms are at their lowest. And women are more responsive to the medication. Neurotypical women, if they're given a stimulant, I don't know how they had that, the research committee approved that, but when they're given a stimulant, they experience the stimulants as more stimulating at that when they're follicular phase. Luteal phase, which is when it's all dropping, ADHD symptoms are at their highest, and they're less responsive to ADHD medications. Think about the implications for girls. Every month, they're taking medicines, and depending on the day, there's a different response to the medication. And the male psychiatrists, even the female psychiatrists, are clueless. And, for some girls, there needs to be major adjustment. There's no guidelines on that yet. We're still working on the diagnostic guidelines. Okay, the implications. Hormonal fluctuations impact symptom level, likelihood of diagnosis, and it varies when in the cycle and in the lifespan. So depending on where they are, in the lifespan or in the cycle, people may or may not respond to medication, or they may or may not be recognized and treated. Hormonal fluctuations likely modulate response to treatments. I think I've been saying that, and I'm going to show you data of that response. Research is needed. Okay, what is menopause? Well, there are 3 stages. There's perimenopause, which is when periods are irregular but haven't stopped. It usually starts in the mid-40s, lasts 4 to 10 years. Menopause is when it's like your menopause when there's been 12 months without a period. And the average age is 51, and postmenopause is all the years afterwards. So menopause is, I guess, a 1-year window. Another quick hormonal reminder. This is just estrogen levels over time. When you're young, not much, then you get into puberty, it goes up. Then the fertility years, when childbearing years, you can see it's kind of steady. Look at perimenopause, because that's going to be relevant to some research I show you. In perimenopause, it's all over the place, up, down, sideways, and all around. And then menopause, it's down. Compare the cognitive menopause with the most common impairments in adults with ADD. This comes from Attitude magazine. Okay, so the first 5 are, as well as the classic triad of inattention, impulsivity, and hyperkinesis, are what's associated with ADD in adult men, and 5 of these 7 impairments are seen in both women during menopause and in adults. So I'm saying that many of the symptoms of menopause, sleep disturbance, mood lability, like temper outbursts, depression, it's also seen in women who are perimenopausal. This may imply an overlap in it is an overlap in clinical presentation and may imply underlying shared brain mechanisms. Okay, is existing studies regarding menopause and ADD, they're almost non-existent. Quinn was the first person to put it on the radar. She wrote about a case in particular. It's a case study of a girl who she couldn't get appropriately medicated until she gave her hormone treatment to balance her, and then she responded to stimulants appropriately. Epperson and Shannon, they're the same group, and they're basically looking at the last two studies. Since then, there's been some more, but I haven't updated this slide. They basically looked at women who've never been diagnosed as ADD, but in menopausal years or perimenopausal years, they're beginning to have executive function problems. So in this study, they treated them like ADD. They gave them Ritalin and they gave them Dex or Vyvanse. I don't know which of the amphetamines it was. But basically, they were looking at cognitive responses to the stimulants in women who had new onset executive dysfunction, and they all did better. Okay, our research is what I'm going to now dive into more deeply. Does menopause cause ADD? um, oh dear, I can't see what I need. Oh, here I get to help. I'm sorry, I got to help myself with reading my things. This information was obtained from reader survey sponsored by Attitude Magazine. You guys know Attitude Magazine. And in this study, we had 3,549 women who had experienced perimenopause or menopause, and of whom 81% had been diagnosed with ADD. They ranged in age from 4 to 84, and we asked them to say at what age were you diagnosed, and the impact of 11 different symptom clusters associated with ADD at each of 5 time intervals, 0 to 9, 10 to 19, 20 to 39, 40 to 59. So big questions we were asking was, when were you diagnosed? How old were you? And then of the many different symptoms, when did they give you the most problems? All right, clinical characteristics. They most of them were combined type, pretty hefty inattentive type group. What's it? I think with adults, actually, inattentive is more common, mainly because the hyperactive piece has been outgrown and what's left over is the inattentive part. So in this population, it was 50% combined and 30 something. It's a little bit heavy on the combined type. I don't know. I don't even know if the difference is statistically significant, but I notice it. What's important here is the comorbidities. They had anxiety and depression and autistic spectrum disorder. I mean, the main thing is anxiety and depression were elevated, very common. And that means these women have the whole profile. It's a comorbid profile that you see in ADDers. It's just part of validating the subject. All right, so looking at the diagnosis, down here at the bottom are the years, 0 to 20, 21 to 30, 31 to 40, etc. The pink line is age of diagnosis. The red line is menopause, and the green line is perimenopause. So what you can see here is that of these 3,000 women, the vast majority were diagnosed during the climactic years. And in fact, it really parallels more than anything perimenopause. Remember the graphs, I mean, the figures that I was showing you about how crazy the estrogen levels go during perimenopause. Anyway, this this has gotten so much attention. I can't begin to tell you all these women first diagnosis. Now, it's a skewed sample. They're attitude readers. They're answering a survey about menopause and ADD. So obviously, it's going to be pulling for women who are concerned about having ADD and older. But nevertheless, even allowing for that, it's just a dramatic figure. Impact of the ADHD symptoms over the lifespan. Look at number. When did ADD have the greatest impact overall in your daily life? And look at that. 40 to 59 is when it had the greatest impact. And then which symptoms first appeared during the perimenopause or menopausal years? Brain fog is the biggie. Sense of overwhelm is pretty bad, but brain fog, that's what most of the people were complaining about. Okay, this is a very difficult, it's not difficult, it's just a lot of information. This is the impact. People were asked to rate the impact of the symptoms from 20 to 39, from 40 to 59, and 60. Let me go straight to the 60. Purple, forget it. Just see it. All the symptoms are having less impact. I don't know what that means. We have to look at that more closely. It's like if you look at the time span, it keeps getting more and more with the biggest impact from 40 to 59. Green is the life-altering impact. But then after 60, it just falls off. It's a little bit like hot flashes and some of the other symptoms of ADD that are at their worst during the transition time and then for many women go away entirely. Anyway, what's going back to 40 to 50, I've drawn attention that during this age period, the symptoms were worst, and the symptoms that were the biggest problem, procrastination, time management, disorganization, emotional dysregulation, sense of overwhelm, and brain and memory fog. So it really increases in that period. Okay, now the question was about hormone replacement therapy, which we're going to go into in our most current study a little bit more. First, they said if you look at it's out of sequence. Look on the right side. Are you taking hormone replacement therapy, or have you ever? And the axis doesn't show it, but basically half had never taken it, and another half either had taken it in the past um, or were currently taking it. And then how did it affect the ADD symptoms? That's question. I'm sorry, the sequence is reversed. What's interesting here is that a substantial percentage noticed no difference. A tiny percentage, that's 5%, said it worsened the ADD symptoms. But a not inconsequential percent, I think the number is like 27%, said it did improve the ADD. Again, we're not measuring this as self-report, but of a huge number of women. And what I'm about to show you is an even bigger sample, which is reporting similar things. Okay, this is what we're going to be presenting this coming weekend. And you recognize the black and colored graph is from the previous one. What we did here, go all the way to the left at subject pool, we had 6,255 respondents. Of those, 4737 had an ADD diagnosis. Of the ones that had the ADD diagnosis, 2,717 had menopause. That left us with 557 were receiving hormone replacement therapy, 417 had done it in the past, and 1443 never had it. The reason I'm drawing your attention to that is it always blows me away when you read these subject flows. You start out with huge numbers, and then you eliminate this and you eliminate all things that you should eliminate, and then you're left with 857 women receiving it and 417 ones received it. Remember, we started out with 6,000. Okay, the reasons, and this is important, we asked the women why were they taking hormone replacement therapy, and can you guys see it, or is it? Because I can see it, but I don't know what you can see. You can't see? Could somebody tell me?
See what, Jeanette? What do we specifically?
Okay, now we're looking at table one.
It's
And
impossible to see on the broadcast.
it's impossible.
Yeah,
Okay.
sorry.
Can we go back? I meant to try and, how do we go back one?
Um, the opposite of going forward. I'm not sure. Rachel, are you around? Can you help
I think she's gone.
that?
Is there a back button?
I'm looking. Backspace. I don't know if that's gonna, oh, it did work.
There you go.
Okay, anyways, can you vaguely see table one? Okay, reasons for taking hormone replacement therapy.
Vaguely.
7% took it because they had brain fog and memory problems, cognitive complaints. Another 19% took it for their physical complaints. They couldn't sleep, they were having hot flashes. 46% took it because of both cognitive and physical problems. So that's important that the women who sought out hormone, the ADD women who sought out hormone replacement therapy, the majority of them had both cognitive and physical complaints. There is because of a terrible study that's now pretty much been totally, I can't say it's disregarded, but the consensus is that there were so many design flaws. It led to doctors and women being afraid of hormone replacement therapy in the United States. So what you can see here is that of the women who finally took hormone replacement therapy, they had like double load of symptoms that they were dealing with. And I just wanted to draw attention in the United and in these is it's about 50% of the women took the hormone replacement. In Europe, the rate is about 4%, is 50%, and in the country, the rate is about 4%. So in the United States, largely due to this study, women and doctors have gotten so scared of hormone replacement that the average rate of taking hormones is 4%. However, in Europe, where they disregarded that study, and among ADD women, the rate seems to be more like 40 or 50%. I think that's noteworthy. All right, if we look at now, what other therapies did the women try? They tried stimulants, non-stimulants, exercise, nutrition, supplements, CBT, mindfulness, and psychotherapy. I wish you guys could see this. The vast majority, 81% tried stimulants, 84% did exercise, and 82% did mindfulness. Nutrition, supplements, also pretty frequent, but not as frequent as the others. And psychotherapy and CBT was the least frequently used, 50%. Now, here's what's important, effectiveness of the other therapies. Far and away, stimulants were declared very effective by 64% of the people that responded. Non-stimulants were 18% effective. I mean, that people declared. So stimulants and exercise came in ahead of the pack.
Hmm.
Wasn't that interesting? Exercise is the 42% found.
Jeanette, you just muted yourself.
No, I think I did that.
Oh,
I'm
okay.
sorry. Unmute.
Unmute. Can you hear me now?
Yes, there you go.
Okay.
I thought I was muting myself. Sorry.
No, it's okay. We're fine. Anyway, this, I wish you guys could see it because it's such an interesting table. But basically, non-stimulants, nobody seems to think, or very few people feel helped by it. Stimulants, no surprise, lots of women felt helped by it. And exercise, I was surprised that it would come in so high. And the rest is kind of, equal. What else did I want to say about this? The hormone replacement is more like exercise in terms of effectiveness. 42% of women said exercise was extremely effective. Looking at the other table, it's about a half of those who took it found it helpful, hormone replacement. So it's about the same as exercise. Now, in terms of treatment, that would imply women who are having trouble balancing themselves, they take stimulants, they exercise, and they consider hormone replacement therapy. Okay. So, conclusions. Presentation, diagnosis and treatment of ADD is very affected by hormonal changes in females. Cognitive symptoms of ADD in females fluctuate over life, especially during the menstrual cycle and pregnancy and delivery. Underlying hormonal fluctuations contribute to these associations, and hormonal manipulation could have a therapeutic value. That leaves us now, according to my thing, we have about 13 minutes for talk. Anybody have questions?
We do have a question in the chat
I don't see it.
from Mary Ann. Do you want me to read it to you?
Yeah, please, because I don't see it.
Okay. I was diagnosed late in life with ADD only 5 years ago. I never took hormone replacements before, and you've gone through menopause already, age 59. Is it worth trying now? I have serious memory issues, sleep issues, anxiety, depression, divorce exacerbated both. I take Wellbutrin, and a doctor wants to put me on Quellbri. Is it safe? No black box warning. Will it affect the antidepressant?
Well, first of all, Wellbutrin is one of those non-stimulant treatments. And if we go by, it's a good, excellent antidepressant. It's pretty sucky for ADD. And you can take them together. I mean, you can have Wellbutrin plus stimulants. It's done all the time. Problem with 59 in hormones, there's a kind of a window of time when it's safe to introduce hormone replacement therapy. But past that window of time, it becomes dangerous. And that's one of the main criticisms of this study, the Women's Health Initiative or something. All the women were well past menopause, in their 60s, when they were put on hormone replacement. And then the other criticism is that they used horse estrogen and Premarin, which you should stay away from, Anyway, it has horse estrogen and it has a progestin in it that's not progesterone. Progesterone is progestation, promotes pregnancy, supports it. Progestin the one that was in the primer and caused abortions. So it's obviously not the same mechanism or the same drug. So back to the question. At 59, I don't know what the recommendation is about hormone introduction at that point. You'd need to speak to an OBGYN. Psychiatrists aren't going to know. Speak to an OBGYN about the safe window of time to introduce sub estrogen replacement or hormone replacement. And then it might help. It's worth a try if it's still safe to do so. And in your case, I would go with stimulants. Forget the non-stimulant. It's I mean, except for depression, it's very good for depression. But I would go with stimulants. And if your doctor is uncomfortable doing that, I would ask, how familiar is that doctor with ADD in adults? Because using stimulants is first line. Okay.
She does say that the Ritalin makes her jittery. So, but there are other.
There are other, and you can adjust the doses. Ritalin, I would try the Adderall family. It's different. It's not, the mechanism is not the same. That's why you're on the non-stimulant. Strattera might be worth it because it acts more like a stimulant. Certainly better than Wellbutrin for treating. Yeah, so try it in terms of that with the stimulant. Do your exercise for sure. With the stimulant family, try the Strattera, try another one, an Adderall, Dex at a low dose. And if that doesn't work, then Strattera is a good path.
Thank you.
Okay.
So Cynthia asks, what are typical unwanted side effects of hormone replacement therapy? Is there any downside to it?
Oh, absolutely. That's why they're afraid to use it. There was a concern that there was an increased likelihood of breast cancer or hormone-mediated cancers. And it seems like a perfectly reasonable concern, but the research has shown that it does not do that. The incidence of breast cancer is no higher in women on hormone supplements versus without. Now, if you have an estrogen sensitive, you have a history of having estrogen sensitive cancer, then you can't take it. Other things. There's a concern about vascular health, predisposition, increased likelihood of stroke, cardiovascular things. It was things like that that made people back away. Again, and I don't think that's been disputed. If you do hormone replacement, I would counsel you to work with an OBGYN who really knows hormone replacement or endocrinologists. They don't do it, but they should. Ultimately, this is something that should be done, not just one doctor. There should be a group because we're so darn complicated. Any other questions?
Sina says standard practice for postmenopausal is to supplement with oral progesterone. It really helps. And she's 58.
Wait, who is saying this?
One of our participants, Sina.
Oh, okay.
Yeah. And Tiffany says, I find that my meds are so ineffective during my cycle, and the emotional dysregulation is so intense. I am told I am too young to consider HRT, but it is so intense on these weeks. 39 years old on Jornay and Wellbutrin right now.
Okay, I'm not an OBGYN, but I do know that if you have very bad premenstrual syndrome, they try serotonin reuptake inhibitors has been very helpful for many people. I don't think, I mean, I would try hormone, putting you on the pill. I mean, that's what they do with that's what they do with women who have terribly difficult PMS. is they put them on the pill. It's not hormone replacement like it would be for menopausal women or postmenopausal, but just putting on the pill to keep the hormone levels steady. So the two interventions, and always I'm going to throw it in, exercise seems so powerful. Pull it in. But the two interventions for this person is I tried the conventional SSRI before periods, and there's years of experience with that. And you can see one's a psychiatrist, and the other one is I put you on the pill to stabilize the hormonal levels. And sometimes they put people on the pill and they no period, just like they stay on it and no period for like months and months. Kuji, there's I can't remember her name, my apologies, but there's been a fair amount of writing about putting women, you could even Google it, premenstrual syndrome, severe premenstrual symptom management with management, and see what comes up. ChatGPT would come up with good stuff. I know those are the two things that are done.
Okay, thank you. We have another, these questions are very specific. So I won't read them to you and you decide what you want to do with them. I was recently diagnosed about a year and a half ago with ADD. I've been taking Vyvanse, which has helped. I'm 55. I am beginning perimenopause, and in the last 3 or 4 months, have been experiencing all the symptoms of perimenopause. Can I take HRT to help with those symptoms, or can I not combine the medications? Is there a certain type of HRT that's better than the other?
First of all, the research that I just showed you is like that's what is out there. There's nothing or very little. I mean, I haven't done an exhaustive literature search, but there's certainly nothing out there to say do this form of HRT versus this form of HRT. That's way too specific. And I also wanted to draw attention to the fact that you're like 51, I think is what she said.
55.
Okay, that's right there, our sample. We're first diagnosed. Uh, I have a question to ask her in a minute, but so you're kind of not atypical, actually. There's a lot of women in that situation. Then she wanted to know, I think you're young enough if you're still perimenopausal and you can find a doctor who's willing to do it, it's worth a shot. Remember, only a third of the women who took the hormone replacement found it helpful. So it's not like there's an overwhelming probability that it's going to help. But you're already on stimulants, you have residual problems, and you're in the right window of time. I'd say go for it.
Okay, thank you.
Oh, the question I had to this person, I don't know if I can get it back, is
Yeah.
is there a family history of ADD? Is she the kind of person who might have been ADD her whole life? Why was it only diagnosed now?
AE, do you want to answer that? Do you want to unmute yourself and answer that question?
She doesn't have to.
Okay, no
Yeah,
problem.
yeah.
Hi,
Oh,
can you
there
hear
you
me?
go.
Yeah.
Yeah. Mhm.
There was no history that I'm aware of in my family. Although I noticed that my son had, I believe, something that was going on, which made me then look at myself. And that's how I was then seeking help and found out.
Okay. So you
But
might be one of those people. I think there are like two types. I think there are the majority is people who had kind of borderline ADD, but with the hormonal fluctuations, it kind of makes the borderline
yeah,
more
it
more.
just I had always felt like there was something going on, but I believe that, like I was masking it for so many years. And
One of my maskers. Thank you.
yeah, so it wasn't until I think, recently where I kind of, sought help to find out what it was. And then I found out that it wasn't, um, that I was just different. There was actually something going on.
Yeah, which was probably a relief.
Yes, very much.
Yeah. All right. Well, I think there's room for there are interventions that you can add to what you're doing that might help you feel way better.
Thank you, Jeanette. Um, Sina added, she said, she's to be clear to what she said before, I got into HRT due to surgical menopause at 50, then worked with a functional medicine doctor to get put on it. I used it for menopausal symptoms, but have found it essential. The big hormonal test that I take yearly is the Dutch test. I do not take HRT for ADHD, but for the physical menopause symptoms. So, Sina, do you have ADHD?
No, I'm not diagnosed, but I'm a coach. So I have, and I work with lots and lots of professional women who are in this age group. And so it was quite a cobbling together of treatment, but mine was specifically for the dramatic responses to surgical menopause at 50. So I was just completely all over the place and all kinds of strange, terrible symptoms right away. So the thing that I can say is that the Dutch tests my saliva and urine, and it tests it. We take like 15 sample tests within a 24-hour period. So it also tests your adrenaline, your all your hormone panel, and it's really very helpful. But I never would have known about it unless I paid out of pocket for it with my functional medicine doctor. This is not, it's very concierge and it's not something that's well known, but I do listen to a lot of podcasts and I've tried to kind of make my way through and it's been really, really essential. So just, I mean, I don't know who's listening in here, but I think more women need to start talking about these things because it's been so helpful.
You know
Thanks
what
for
what I found, I'm sorry, did I cut you off?
No, I'm good. Go, you go.
What I just found the statistic that 50% of European women get hormone replacement versus 4% here. I got to double
Yeah.
check where I got that statistic, but still, it is a huge
Yes.
discrepancy. I just,
Yeah. Yeah.
you know,
And the thing that I found also with the hormonal tests, and I get it, I get regular oral progesterone, but I go to a compounding lab for a suppository for, the other side of the equation. So, but it was really because I went deep diving on how to kind of normalize the symptoms because it was quite abrupt and quite awful at first. And so I did a lot of research, and we are woefully undersupported as peri and menopausal and postmenopausal women in our healthcare system.
oh
And
yeah,
yeah,
but it
yeah,
is changing. I
it
mean,
is. It is.
it's
Yeah,
ridiculous how long it's taken to change. You know,
yeah.
we are in the 21st century, and medicine's been pretty cutting for at least 100 years.
Right.
But at least it's happening.
Jeanette, would you say that we need to be our biggest advocates and make things change as women, like educate ourselves and go in and be demanding change?
Absolutely.
Yeah.
Absolutely.
I
And
also think it's notable. This is Sina again, but I also think it's notable that my functional medicine doctor is a 60-year-old woman. My general practitioner is a 58-year-old woman. Like it is. People are experiencing a lot of the same things, and then my entire practice is professional women. Most of them are 30 to 60. So lots and lots of just, I don't have the data, but I do have the lived experience, and I kind of, think that that's kind of important too.
the hormonal fluctuate, which is what are you referring to with that?
Just the leveling out of when your hormones drop out,
Ah,
they're the clocks of our, they're the regulators and the, radiators of our lives. They keep everything kind of within that window of tolerance. So, I'm a big advocate for it. So I do not have the markers in my genetics to be prone to certain cancers, and I think that's kind of important too to rule out. So, but many, many people are good candidates for it.
oh yeah, for sure.
Yeah. So thank you for tonight's discussion, everyone.
You're welcome. Do we have any other questions? There's no other questions in the chat. Does anyone want to raise their hand? We have a couple more minutes.
Well,
Oh, Ellen, you muted yourself. Unmute yourself.
Ellen, you're mute. Oh, no.
Um, so we talk about HRT and it being helpful. Are you thinking or have you observed that it's most helpful during those years of when the changes are the most dramatic and that it's not or counter, indicated as women get older? Is that how it works in Europe and it sounds like that's how it works here, but what do we know about that?
I don't know what we know. I haven't done the literature search yet, but I do know that when I see our data, it all falls off. I mean, the complaints just go away when the women are older, which implies, I don't know, either our N was very small and we just didn't get anything there. I do have to check all that. But if it looks, if what we see there, and that was with the smaller sample, now we have much double the size sample. If it looks like that again, then it would say things are getting better. And actually, when we were speculating, we said there might be two reasons. One, as you get older and you're not like in between old parents and young kids and all the multiple responsibilities that you have when you're in your 40s and 50s, that part of it might be life is less complicated, so people are functioning better. And then the other thing is, which I'm a reductionist, and I'm always inclined to look for biological explanation. Uh, our bodies adjust, just like most women stop having hot flashes and stop having the sleep problems. Bodies adjust. So does that answer your question?
Yes and no,
Oh,
because
yeah, I can't yet. I mean, the science is not there.
okay. So yeah. Um, it sounds like there's a lot that's more unknown than known. And
Oh, for sure. It's really it's one of those cutting edge type areas.
yeah, well,
We have two more questions.
thanks.
Cynthia was wondering, is it something that should be done prophylactically? Like, do you think HRT should be prescribed as a default to postmenopausal women, even if they're not experiencing symptoms?
Hmm.
It has risk associated with it. So I wouldn't facilely give it to every woman who's postmenopausal. I mean, there should be an indication. But if there are indications, and I can't tell you how, I'm sure you guys in your practice, don't you have like menopausal, perimenopausal women complaining about they think they're dementing, they don't know what's wrong with their brain, that sort of thing. So I think there should be an indication, but if there's an indication, I think it should be something that should be tried. Probably try the stimulants first and add this additionally.
Hmm.
Although the hormones make your skin pretty and do other things. You might have other reasons that you want it, but for the cognitive stuff, I'd start with the stimulants and go from there. And also when people are like not responding well to the stimulants, younger girls who, one part of the month they're doing okay and another, with them, there should be hormonal leveling off.
Okay. Stacy was wondering, are there any articles or books about CBT for perimenopause, or would you refer us back to your book with Mary?
Yeah, I'm laughing because Mary's we're doing with me and we're doing the research on the menopause together. No, there's no book and we haven't written it yet. But I think it's the CBT would be the same. Yeah, refer them back to that book. I mean, it wouldn't be any different with menopausal people. So shouldn't be.
You mean you
Okay.
mean the book that you and Mary wrote? I have it. It's somewhere. I don't know where it is.
What's the executive? What is it? I've learned to call it CBT for ADD, but that's not the title of the
Yeah,
book.
I don't. I have it here somewhere, and no, of course I can't find it. But um, yeah.
Yeah, it's a good book.
Look up Mary Salanto. I think Mary's name is first. So,
Yeah.
and it's great. It's a workbook.
Yeah, it's a workbook. Although it's meant for therapists, we never wrote one for individuals. But I tell people buy the book. It's got a nice review of the literature. All the concepts are described in each section. So
Hey, I think
And it
that's
sort of has a how-to, things to
yeah,
think about. There's an educational piece. You know,
yeah, no, it's very useful. I was talking to somebody in Taiwan because it's been translated into Japanese and Korean, but it hadn't been translated in Chinese. So I was saying to him, we need a translation into Chinese. And he agreed, and he took it around to a couple of publishers, and they said the book was too old because it was written, I don't remember what year.
like at least 6 years ago.
Yeah, no, actually it's longer than that. But it doesn't matter. It's still totally fresh. So
Well, yeah. Well, the information about ADHD is
a little
pretty
dated.
classic and standard. Some of it may be a little outdated, but the whole approach and the way you guys did it is, um, it's sequential. It's,
Yeah,
like it builds on itself. And the only piece that I must have talked to her about it several years ago was, adding a piece for mindfulness. And
she's
you're,
gotten into mindfulness now. But at the time that we wrote the book, mindfulness was,
well, yeah,
was not, you know,
it wasn't what it is today.
yeah. But remember on that what the women had to say, mindfulness was helpful to only about a third.
But exercise, whoa.
Exercise is like way up there. Yeah.
Yes, do yoga, do Pilates, do
Uh,
something.
Exercise is a panacea. It's a panacea. And the fountain of youth. Those guys that were always looking for the fountain of youth, they didn't know that in the process of looking, they were embracing the fountain of youth. Except for when they killed people. That's a whole new.
Right,
I think
Anyway,
too that when people think about exercise, it's important to expand thinking about it. It doesn't have to be going to the gym. Just get out and walk. Just move your body, dance at home. Just move your body,
Yeah,
right?
move your body, dance at home.
jump up and down,
Yeah.
you know, good for
And
the
it can be
bones
a little
too.
bit at a time. You don't need to carve out an hour to do something. A little bit at a time,
You guys
whatever
are
works.
motivating me. As soon as I'm getting off the show, I'm going to turn on my YouTube and do some dancing.
Oh, great.
I love it.
Yeah, so maybe this is a good positive note to end on, unless there's any more questions. Joni, are you seeing anything else?
Well, AES, was it any specific type of exercise? Was it aerobic in the study that you did?
That's a good question. No, in terms of what we got, the question was, what did you find was helpful? It's like we'd like to do when we finally write this up, we'd like to do some follow-up on some of the questions. So
Yeah,
then
that'd be
questions
interesting.
like which stimulant, what kind of exercise, go in a little bit.
Well, you'll keep us posted.
Yeah, I will, definitely.
Okay.
So it's been lovely talking to you, ladies.
You got a lot
Jeanette,
of thank yous in the chat.
Jeanette, thank you so much. This was uh, information that I think people don't have
Yeah,
access to, and it's not that familiar. And we really need more research with women. We know that in general, and ADHD and the different phases of, our life.
yeah.
So
It's
keep
been fun playing with you ladies.
you